So my mission is to discuss ablative, image-guided ablative therapy in early stage disease. And just so the goal is to define percutaneous image local ablation, review the methods for this, because there's actually a variety of methods, review results, and then identify the role of this ablative therapy in early stage HCC. So just to remind, what I'm talking about really is early stage and very early stage. So we're talking about less than 5 centimeters for one tumor, less than 3 centimeters for 3, and very early stage is less than 2 centimeters in patients who have preserved liver function and preserved overall function. This we've already seen before. And we also have now seen the BCLC algorithm, which has ablation as a prominent role in these categories of early and very early stage tumor. So just to define our percutaneous image-guided local ablation, this involves the introduction of a drug, chemical, or energy, which is the most common method, directly into a tumor under imaging guidance, usually ultrasound or CT, in some places MRI, to destroy visualized tumor plus a surrounding zone, typically a margin of about 5 to 10 millimeters. The larger within that range, the better. And this is usually considered a curative therapy. It involves usually placing one or more needles into the tumor, and you want to avoid damage to biliary structures, vascular structures, or sensitive extrahepatic structures. So I divide ablative therapies into chemical injury, thermal injury, biologic injury, and bioelectrical, and the highlighted ones are really what are more commonly used, and the underlined ones the most commonly used. So early on, ethanol ablation, or PEI, which is percutaneous ethanol injection, was an early modality, but this has really been surpassed by the better results of hyperthermic ablation. And hyperthermic really consists of radiofrequency ablation, which is the most extensively studied, but microwave ablation, I think, is really surpassing that at the current time, and I can't remember the last time I've done a radiofrequency ablation. Cryoablation has limited experience in HCC, as does irreversible electroporation. So percutaneous ethanol ablation, just to remind everyone, this was an early method and involves local cytotoxicity of the injected alcohol with cell dehydration, protein denaturation, and tumor vessel occlusion. And the alcohol will diffuse into the soft HCC, but contained by the surrounding firm cirrhotic liver. I'm not going to really go into technique. I'll just show an example of a patient where this was not necessarily an early stage, but because I haven't done that many ethanol ablations lately. And this is someone who had a caudate tumor. 2 months after other treatment, has a new caudate lobe lesion where we put a needle into it here, injected alcohol, and a follow-up. There's no ablation out to 15 months. Excuse me, there's no recurrence out to 15 months. And overall, the complication rates have been very low for alcohol ablation, with death rates of typically less than 1%, and major complications also typically in a very low percentage. But as I said, alcohol ablation is really not practiced very much anymore. It's only in special situations. And what is the mainstay now is hyperthermic ablation for image-guided treatment of this sort, and radiofrequency and microwave. And the goal here is to generate adequate elevation of temperature throughout the target volume to produce non-viable tumor. And usually this involves trying to reach a minimum of greater than 60 degrees, which will achieve immediate protein denaturation with irreversible cell damage and coagulative necrosis. Lower temperatures will take a longer amount of time. So here's just a little picture showing how we put typically 14 to 17 gauge needles, depending upon the exact system, under ultrasound or CT, directly into the tumor. What the size of the probe and the number of probes you may need will depend upon the size of the lesion and the margin you want to achieve around it. Generally, we like to traverse normal tissue if possible, so that we have a little track and we'll have a little less chance of bleeding or seeding of tumor. These can be done under moderate sedation or occasionally general anesthesia, and it's usually an outpatient procedure. Very rarely have they required admission. And it's usually one treatment session, unlike alcohol injections, which are usually multiple treatment sessions. The size of the ablation zone with this is traditionally felt to be best if the tumor is up to 3 centimeters, but with microwave that's been growing a bit. You want to avoid injury to vital structures around the tumor, so that could be the gallbladder, the bowel, or central bile ducts. Questionably, the heart, I think that's more of a mechanical issue. If you inadvertently place your needle wrong, heat really should be well tolerated. There are tricks you can use to get around this by hydrodissection, putting fluid in to separate your tumor from the vital structure. Artificial ascites, we've done that very little at Yale, but that is described in some places. You can switch over to a surgical ablation if it's near a vital structure, or a non-thermal technique such as alcohol or irreversible electroporation, which is we're just starting to use here. Another limitation is a thermal sink from adjacent vessels. Typically, the greater than or equal to 3 millimeters is considered a size, a vessel size that becomes a problem for carrying the heat away. Microwave does appear to be less affected by this, as of course do non-thermal methods. And we don't generally like to directly puncture subcapsular lesions. Perhaps there's an increased risk for bleeding intraperitoneally and tumor tract seeding. At least in one study, this was felt to be a more important issue. So this is an example of someone who's not a great candidate. We actually discussed him at our tumor board yesterday, so those who were there yesterday will remember this image, but I had this on the slides before that tumor board. And he has a segment 2-3 anterior subcapsular tumor surrounded totally by bowel. It would be very difficult to get a needle in there, and even if you did, how are you going to protect the bowel? And it's difficult to generally separate the bowel in this location from a tumor. Radiofrequency ablation involves placing a needle in that will create an alternating current that creates agitation of ions and friction-related heat. You want to avoid a temperature greater than 100 degrees because that can vaporize and cause carbonization, which will increase impedance and limit the propagation of your electrical field beyond that level, which could be immediately around the needle. And then there's also issues where how safe it is if you have a pacemaker in the proximity to where you're treating. There are a variety of tricks. Radiofrequency ablation generally is felt to be good up to about 3 centimeters. There are a variety of tricks even to achieve this level or slightly larger sizes using multi-modified electrodes. We have internal cooling to prevent the charring immediately around it that limits the volume, expandable electrode needles, and multi-probe arrays. Saline injections have been tried to increase the conductivity and methods to decrease loss of your ablation from the surrounding vessels, and then overlapping. These were probably the 3 most prevalent devices, expandable tine systems for the first 2, and then this was internally cooled with saline to prevent the charring immediately around it, whereas this achieved greater volumes by having multiple tines spread throughout the tissue. And this is just an example of someone who had a well-differentiated hepatocellular carcinoma of 2.8 centimeters in hepatitis B, and he was a significant coronary artery disease. I don't recall him being a resection candidate. And you can see this was a multi-tine system. On ultrasound, it's hard to see the tines, but I'm kind of pointing out 2 or 3 of them here. And then you can see this echogenic area afterwards encompassing the mass. Microwave ablation involves also placing a needle, which is an antenna, into the tumor that creates a high-frequency oscillating electromagnetic field. This agitates polar molecules, which is principally water. That creates kinetic energy, friction, and heat. And compared to RFA, this tends to give a larger radius of ablation. So it's a little bit better for larger tumors. It's faster. You don't have to use a grounding pad, so it makes it a little easier for the operator. You get higher target lesion temperatures. It's more homogeneous, less affected by the tissue impedance. You don't have to worry about the charring, really. That'll limit the extent of your volume of ablation. And it's less affected, as I said, by heat sink effect. And you can have more easily multiple probes in to treat a larger area. Postablation does give, there can be side effects afterwards, pain, nausea, fever, chills. This malaise and fatigue and anorexia can occur in about 1/3 of patients or more and lasting a week or so. So radiofrequency ablation for very early and early HCC tends to have complete ablation on imaging, first imaging, about 90% or greater. If it's less than 2, even higher percentages. And 5-year survivals, remember this is a select early stage group, of 60 to 85%. Tumors greater than 3 but less than 5 centimeters have a lesser degrees of complete ablation. It's been described up to 74% on average. Pathologically, the results are less. This is an article from 2018 where they looked at explanted livers for liver transplant, And their imaging response was 78%, pathologic response was 62%, with smaller tumors having more favorable and further away from the vessels, more favorable responses. Compared to alcohol, which is really heat-based systems have supplanted, this meta-analysis of 5 randomized trials showed improved results across the board, early complete ablation, number of sessions needed to achieve that, local recurrence rates at 3 years, and overall and cancer-free survivals out to 3 and 4 years, yet no significant difference in adverse events. So there's really a little role if someone can have a heat-based ablation to do an alcohol ablation at this time. Microwave ablation has similar results for small tumors, but for 3 to 5 centimeter range is where the ablation seems to be more successful, hitting 90%, and that's better than RFA. 5-year survivals are not too dissimilar in the 78% description. We'll go over some more trials on that. This study comparing RFA and microwave showed that the bottom line here is that RFA was inferior to microwave ablation for HCC within Milan criteria, but comparable if it was a single tumor less than or equal to 3 centimeters. So the gain for microwave is for that 3 to 5 centimeter tumor, the larger tumor. Still in the early stage, of course. There are, of course, limiting factors, poor prognostic factors of poor liver function, poor performance, local tumor progression, aggressive tumor biology, such as microvascularization, high AFP, and poorly differentiated tumors. Complications seem to be very low, with the more common ones being tumor tract seeding, and that kind of comes into our whole biopsy discussion we had before, and hemorrhage. Liver abscess, I've seen this twice, most recently just this past week on someone about 8 months after an ablation. They had developed an abscess in a cavity. Cryoablation involves putting a needle in it. You send a compressed gas, and when it expands at the tip, it creates, will decrease the temperature. And most reliable cell death will occur if you can achieve a temperature less than or equal to 20 degrees in the surrounding tissue. The advantage is actually the ice ball is very visible under CT. It's likely less injurious to surrounding structures, such as nearby bile ducts. And although one downside is maybe a possible increased risk of hemorrhage, although that seems to be slight. So this is an example of a patient that had cryoablation done because it was a very central, small HCC near, just inferiorly near probably the left hepatic duct, right? Here you can see the needle placed, and you see the hypodense ice ball around it. And normally this would be a bigger ice ball, but I'm sure that what is going on here is the thermal sink is reducing the size that it can achieve. Nevertheless, on follow-up, that lesion was ablated. Cryoablation has limited clinical data, but this one study from 2018 and a cohort of patients treated with RFA or cryoablation, they saw similar overall survival and cancer-free survival. Irreversible electroporation is probably one of the newer ablative methods on the block, and this involves placing 2 or more needles to create a high voltage application and creates irreversible increase in cell membrane porosity and cell death. And compared to thermoblative methods, has a more sharply marginated ablative lesion. It's not limited by flowing blood, so you can use it right up to the margin of vessels. Connective tissue is not affected, and it preserves adjacent structures, but there's insufficient clinical data in HCC at this time. So what about comparing this to other methods, so ablation or resection? So there's actually been inconsistent results across, I think, 6 randomized trials. So comparable overall survival and recurrence-free survival were shown in 3 randomized trials. Comparable overall survival but reduced recurrence-free survival was seen in 2 randomized trials here. In the second one, there was no significant difference for tumors less than 2 centimeters. This one study showed the resection had superior overall survival. Okay. There were some questions about adequate ablative technique in this study, and some patients turned out to have actually benign disease. In all these studies, still, postoperative complications and hospital stays were typically significantly higher with resection in all of them. Then this analysis from the National Cancer Database looked at 18,000 patients who were undergoing either RFA or resection. There were variable sizes and numbers of tumors. RFA had better post-treatment outcomes in terms of length of stay, unplanned readmissions, and 30 and 90-day mortality. The full cohort had better overall survival for resection. However, there was a subset, if you had of comparable survival, were seen in those with worse liver status, those who were older, and those who had smaller tumors. Then RFA or resection for very early stage, again, that tumor is less than or equal to 2 centimeters. And then these two studies showed no significant difference in overall survival, 1, 2, and 3 years. And overall survival, no significant at 1 year, but resection better at slightly later years. So we're seeing somewhat inconsistent results when you look at different studies on this. And then what about microwave ablation? So those other studies were RFA. And microwave, remember, seems to be a little bit better for larger tumors and gives you a more homogeneous ablative volume. No significant difference between microwave ablation and resection in this meta-analysis here. Microwave did have significantly shorter operative times, less blood loss, and fewer complications. So the other thing to realize is that ablation should not be considered in isolation. And all the treatments we're talking about today should not be considered in isolation. We have to think of all these treatments in combination with other treatments, either as a single-time approach or over time as patients' disease mandates, right? So ablation may be 2 image-guided therapies, ablation plus transarterial therapy, and may be combined with surgery, may be combined with systemic therapy, as Stacy Stein discussed a little earlier, and we still don't know the full role there, or as a combination with liver transplant. So what about looking at ablative therapies and combined with chemoembolization? So chemoembolization before thermoablation can increase the ablative volume that one may achieve, perhaps likely from decreasing the heat sink. For tumors up to 3 centimeters, there's no significant difference in combining with chemoembolization, but there probably is a benefit for tumors 3 to somewhere between 5 and 7 centimeters. Greater than that, uncertain benefit, and if you have several tumors, perhaps a benefit as well. So this study from 2013, randomized trial of combining TACE with RFA, compared to just RFA alone for solitary tumors up to 7 or up to 3 centimeters, up to 3 centimeters, and significant improved overall and recurrence-free survivals out to 4 years. These others, what about chemoembolization and local ablation for tumors larger than 3 centimeters specifically? So RFA and TACE significantly improved survival at 1 and 3 years only if it was an HCC greater than 3 centimeters in this study from 2013. And then TACE plus either RFA or microwave ablation. TACE plus microwave ablation had a better response for tumors 3 to 5 centimeters, although no significant difference in survival rates. This is just an example of a patient who had a 4.1 centimeters, so still early stage tumor, but bigger than 3. In the middle of his liver, I think it was segment 4. You see the classic arterial phase enhancement and washout. And now he has he was treated with chemoembolization and RFA. 40 months later, he has still no recurrence in that tumor. And in this study, looking at it was a network meta-analysis. They looked at local tumor progression in 3 years in patients treated with a combination of local ablation and a variety of other treatments. So they found that local tumor progression in 3 years, RFA plus radiotherapy or TACE was better than resection, although resection was better than RFA as a sole treatment. And overall recurrence, resection was best for less than 3 years, but this combination of RFA with some adjuvant therapy was better at greater than 3 years. So there are advantages, as I alluded to along the way, of ablation. It's minimally invasive. It can be done as an outpatient treatment, which is almost always how we do it, and occasionally a minimal hospital stay. Low mortality, low morbidity, minimal damage to non-neoplastic liver tissue, and it's usually easily repeated. So in conclusion, I can say hyperthermic ablation is highly effective for local control of very early and early stage HCC. Microwave ablation appears better for control of tumors that are in the early stage but greater than 3 centimeters. Local ablation is probably comparable to resection for very early stage tumors, that are up to 2, and resection may be better than RFA for tumors greater than 2 to 3, but better results with microwave and combining local ablation with a transarterial method. Thank you.